Catherine Mickelson. I'm the Executive Director of the North American Thrombosis Forum. Thank you so much for joining us this evening for the first in a series of patient webinars entitled CTEPH and You. Now, without further ado, I'm pleased to introduce our faculty for tonight, Dr. William Auger and Dr. Kim Kerr. Dr. Auger spent more than 30 years of his career at the University of California, San Diego, where he focused on the evaluation and management of patients with CTEPH and pulmonary disorders, and he developed one of the leading CTEPH programs in the world. In 2018, he retired from UCSD as a professor of clinical medicine and accepted a faculty appointment at Temple University in Philadelphia until 2021, and he now serves as an emeritus professor at UCSD. Dr. Kim Kerr is clinical professor of medicine and vice chief of the Division of Pulmonary Critical Care and Sleep Medicine at the University of California, San Diego. She has been part of the pulmonary vascular program at UCSD since 1993, and her clinical and research interests focus on chronic thromboembolic pulmonary hypertension, CTEPH, which is what we are here to learn about tonight. So thank you so much, Dr. Auger and Dr. Kerr, for joining us. We're delighted to have you. And I will now pass the mic over to you.
Thank you so much to the North American Thrombosis Forum for inviting me to participate in this exciting discussion tonight. I also want to thank Dr. Bill Auger, a longtime friend, colleague, and mentor who really taught me so much about this disease. So he's the real expert here, and looking forward to his chiming in and making comments and probably some very silly jokes as well.
Yeah, I'm well known for that, Kim, as you know.
Yeah, I know.
Okay.
So we're going to talk about CTEPH 101. We're going to define CTEPH and its relationship to acute thromboembolic disease. We're going to review how it develops and how common is it, and what can be done for CTEPH patients. So what does CTEPH mean? It stands for chronic thromboembolic pulmonary hypertension, which is really quite a mouthful. And so that's why we refer to it as CTEPH. And chronic thromboembolic pulmonary hypertension is high blood pressure in the lungs from chronic blood clots. What do we mean by pulmonary hypertension? Everybody's familiar with the usual systemic hypertension, where we all go in and we have our blood pressure taken by physicians, and there's a threshold for it being too high and it needs medicine, or it's normal. We're talking about pulmonary hypertension, which is high blood pressure in the arteries in the lung. And just sort of a quick review of some physiology to understand it. So here's a nice diagram on the right. If you look at this diagram over on the right, there's the heart. And where you see the blue, that's blood coming back from the body. That's blood coming back from the veins that doesn't have oxygen. And it goes to the right side of the heart, which has two chambers. And the heart is a big muscle, which really functions as two pumps. So the right side of the heart, the job of it is to pump this blood that doesn't have oxygen through the arteries in the lungs. And as it passes through the arteries in the lungs, it picks up oxygen, and then it turns red, as you see there. And so those are the veins going back to the left side of the heart. And the job of the left side of the heart is to then pump this blood with oxygen out to the body. When normally the pressures are quite low in the arteries in the lung. And when they're elevated, that can be caused by a number of diseases. The one we're going to talk about is when there's complete blockages in the arteries in the lungs, or partial blockages caused by chronic blood clots, as you can see sort of pictured there. Great, thank you. Well, what is CTEPH? CTEPH is acute emboli. It starts off as acute blood clots, so fresh blood clots that usually come from veins in the arteries or legs. So here's a very nice video, and these are fresh blood clots that have embolized, but over time, in a minority of patients, these blood clots, rather than being dissolved by the body, which is the normal response, form scars in the artery. And so they cause blockages and narrowing in the arteries. And this typically happens over months to years. Most people, after about 3 months of anticoagulation, these clots will go away, or the majority of them will. But in patients with CTEPH, that's not what happens. And the consequence of this is it puts a strain on the right heart and causes that pulmonary hypertension we talked about. And it makes the right side of the heart have to work harder to pump the blood through the arteries in the lung. Essentially, it's sort of a plumbing problem with these blockages in the lung, that you have blocked pipes in your lung. So everybody thinks about when we talk about blood clots, things that look like the picture that you see on the left, kind of like when you cut your hand and your hand bleeds. And so once the bleeding stops, you get this fresh jelly-like clot over the area where you had cut yourself. And that's how these clots start. However, with chronic thromboembolic disease, they're really quite different. So imagine that after the bleeding is stopped and you eventually form a scab and the scab falls off, and you're left with this pale scar on your hand. And that's what we're seeing in the arteries in the lung. And if you look at that picture on the right, that's a nice demonstration of chronic blood clots that are in there.
And this is, and I'll just say a few words here. And this is so much of the reason why we're doing this webinar series with all of you, and so you can ask the questions, because people who have experienced an acute pulmonary embolism, you know, there's so much to think about as you're being treated for this disease. And the nice thing is that after treatment with anticoagulants, most folks who experience an acute pulmonary embolism, the clot will resolve. But there are a certain percentage of individuals that will go on to develop CTEPH. And we're going to talk about that in greater detail. But again, this is the motivation for this webinar series to really try to answer your questions as to, you know, am I at risk? Is this going to happen to me? And what's the chance of this occurring to me? This is kind of a just overview of a timeline, if you will, of how you start with an acute clot and you go on to develop CTEPH. So I'm going to move to the next slide and to try to answer, or the next couple of slides to try to answer the question, well, how common is it? Kim, how common is it?
Well, a lot of people have spent a lot of time looking at this, and we think it's probably about 3 to 4% of patients who have an acute blood clot will go on to develop pulmonary hypertension from chronic blood clots. You want to add anything else, Bill?
No, I think this is a complicated cartoon, but the bottom line is you're really talking about there's a 3 to 4% of folks who experience an acute embolus go on to develop CTEPH. So it's the majority of folks will resolve their clot on anticoagulants, but there are a small number of patients that go on to develop CTEPH. But of course, it's not that easy. And Kim's going to tell you, or Dr. Kerr will talk to you a little bit about, you know, CTEPH is only one of the issues that needs to be discussed for folks who have experienced an acute PE.
So we know that, there are lots and lots of people, hundreds of thousands of people who have acute pulmonary emboli in the United States every year. And as Dr. Auger mentioned, about 3 to 4% of those patients will go on to develop CTEPH. But many more of those patients still have symptoms after being treated, that they never really go back to normal. And it may be due to CTEPH. It may be due to other medical problems patients have. Sometimes it's deconditioning because you haven't been able to exercise for some time. There are a number of reasons why patients may be symptomatic after they've been appropriately treated for the pulmonary embolus. And it can be challenging to sort out, but it's important to look for CTEPH and all treatable causes of shortness of breath in patients who don't return to baseline, back to normal, after you've had your blood clot treated.
Let me go back to this slide again. And you'll see that the outer circle encompasses all the patients who've been experienced pulmonary embolus. And you'll see that tiny little black circle that's labeled CTEPH. And that's the 3% of folks, or 3 to 4% of folks that go on to develop CTEPH. And within that, you'll see a bigger blue circle. And this just simply represents a group of folks who develop old blood clots in their lungs, but without pulmonary hypertension. And that's the basis for this next topic. So what is, it says chronic thromboembolic pulmonary disease, and that's called CTED, if you will, or what we used to refer to as CTED. So Kim?
Right. So there are some people who have residual blood clots, so chronic blockages in their arteries, but it's just not severe enough that they have pulmonary hypertension, and we define that as a mean pulmonary artery pressure greater than 20 at rest, because that's usually when we're measuring, when we do it by echocardiogram or by a right heart catheterization. So when they're resting, they don't have pulmonary hypertension. But these people still, some of these people still are short of breath, and it's related to these blood clots, and it can be from a number of causes. It could be because the pressures really go up abnormally when you exercise, or sometimes it's because what we call elevated dead space ventilation. So there are parts of the large parts of the lung that aren't functioning normally. The lung can't work unless you have blood flow going through the lung to pick up the oxygen. How often this happens, we're not sure yet. This is a very new area of pulmonary vascular disease that we're starting to explore. And what are the treatment options? Sometimes there are options for these patients as well. Anything else you want to add, Dr. Auger?
Yeah, and that's a very nice explanation. Because folks, after experiencing a pulmonary embolism, they're on their anticoagulants and things are getting better, but things just don't quite get back to where you were before the acute PE. And, you know, these are the kinds of things that can occur. And we just don't know how often it happens. It's probably more than the 4% of patients who go on to develop CTEPH, but we're just not sure. And again, you know, this is an area of active research. And the next question that folks typically want to know, well, you know, what's my risk for developing CTEPH? And Dr. Kerr will discuss this with you right now.
Well, you can see here there have been a number of risk factors associated with the development of CTEPH after an acute pulmonary embolism. But keep in mind that just because you had any of these doesn't mean that you're going to develop CTEPH. So obviously the biggest one that we think about is someone who's had a history of an acute pulmonary embolism. People who've had recurrent episodes are also at increased risk for developing PE. We talk about unprovoked pulmonary embolism. So that's why we're not really sure why it happened. Sometimes we know why we think someone had a blood clot in their leg and a PE. For instance, someone who broke their leg and their leg was immobilized in a cast for a long time. That's a risk factor for developing a clot in your leg because your leg's not moving, and then the pulmonary embolism. That would be an example of a provoked PE. But someone who has an unprovoked PE, that's a risk factor. people whose right heart wasn't working well at the time of the pulmonary embolism, and typically that would be identified by an echocardiogram that was done at the time of the acute PE. Obviously, people after treatment who have pulmonary hypertension are at increased risk. People who have large pulmonary emboli are also at increased risk for developing this complication, as well as people who, before the diagnosis of the pulmonary embolism, have been symptomatic for weeks, and then patients older than 60. You want to talk about the medical risk factors, Bill?
Yeah, I would. And so those are risk factors that are related to the having experienced the pulmonary embolus itself. And so, but people also want to know, well, gee whiz, are there some underlying medical conditions that I have that place me in increased risk of developing CTEPH? One is if you've had a previous history of cancer. If you're on thyroid replacement medications, Synthroid, for example. So if you've had low thyroid problems in the past and the doctors have put you on medications to treat that. Certain kinds of blood groups are at greater risk of developing CTEPH. If you've had chronic inflammatory states, let's say inflammatory bowel disease, Crohn's disease, ulcerative colitis. If your spleen's been removed in the past, that places you at greater risk of developing CTEPH after having experienced an acute PE. And if you have certain kinds of shunts and intravascular devices, long-standing or long-dwelling intravenous catheters in the treatment of your cancer, or a ventricular atrial shunt that those people with hydrocephalus have had placed in order to treat that condition. Now, I always like to emphasize with everybody that if you have one of these problems or one of these medical conditions, that doesn't mean you are certainly going to develop CTEPH. It just puts you at greater risk. And as we're about to discuss, so after your pulmonary embolism is being treated and you're still having symptoms and you have one of these underlying conditions, it's a good idea to remind your doc, hey, I'm still short of breath, or I'm still having a hard time, walking upstairs, and I just don't feel like I'm back to my usual way of doing things. And, I have these other conditions, do I have CTED? Do I have CTEPH? So it's always good to know that you might indeed be at increased risk for developing CTEPH or CTED after acute PE if you do have one of these conditions. I just also wanted to, now the webinar series that we are putting together for all of you is to, be here, answer some of your questions about CTEPH and CTED. And knowing that you're a group of patients that either have CTEPH currently or have had experience in acute pulmonary embolism. And it's a three-part series. The first part, which we had focused on this evening, was entitled CTEPH 101, meaning it's just the basics of CTEPH, and to address the questions are what is my risk, and to answer some of those questions for you. We're also going to do in our next webinar, we're really going to talk about what tests need to be done in order to diagnose CTEPH or CTED. And finally, the third webinar series is going to be on how is this treated, because the good news, if you do develop CTEPH or CTED, is that there are treatments available for this, and often treatments that will provide a cure for CTEPH. And we'll talk about those things in great detail. The next couple of slides here are simply to not leave you hanging, because I don't know if you will be able to attend some of these future webinars, but to indicate that, diagnosing CTEPH is really what your doctor should be doing for folks like yourself who are still having some problems with cardiopulmonary symptoms after treatment for an acute PE. The other patient groups that we are concerned with are those patients with pulmonary hypertension. We want to make sure that they don't have CTEPH, as well as patient groups that have unexplained shortness of breath during exertion for no clear reason. A number of studies are done to screen for CTEPH, an echocardiogram looking for pulmonary hypertension or strain on the right side of your heart, lung ventilation perfusion scans that'll detect perfusion defects, and there are other studies that are more diagnostic, such as CT scans and pulmonary angiography, and where we can actually detect the old blood clots in the pulmonary arteries and make the diagnosis of CTEPH. What can be done for this? There are a number of things that can be done for people in whom we make the diagnosis of CTEPH. There's a surgical procedure called the Pulmonary Thromboendarterectomy. That's a mouthful, isn't it? Which we refer to as PTE surgery, where the surgeons can actually carefully go inside the pulmonary arteries and carefully remove these blood clots. For those patients who don't have surgical disease, there's medical therapy, as well as something new that's actually becoming increasingly popular in the United States. For inoperable patients, it's a catheter procedure in which a balloon is placed across the lesions in the pulmonary arteries, and balloon is inflated. It's called balloon pulmonary angioplasty in order to decrease the narrowing in those pulmonary arteries that are due to the old blood clots. And we're going to discuss all of these procedures in greater detail in future webinars. This is a nice example of the material that Dr. Kerr showed you earlier in our discussion, the chronic blood clots that are removed from the pulmonary arteries with a marked improvement in pulmonary pressures and pulmonary resistance as a result of that operation, the improvement in perfusion as a result of removing those blood clots. And this is just some images showing the same kind of things in the smaller or distal vessels in the lungs, where a balloon is inflated to decrease the narrowing and improve blood flow to certain lung regions. I hope that we were successful in talking about CTEPH and some of the fundamental aspects of what is CTEPH and how often it can occur following an acute pulmonary embolism. We know that this is an under-recognized disease and underdiagnosed, which is part of the reason why Dr. Kerr and I do so many of these webinars, not only to patients and their families, but also involved in teaching other physicians around the world. There are a number of clinical factors that place patients having had an acute pulmonary embolism at risk for developing both CTEPH and CTED, and the evaluation for these disease states should occur if you're still experiencing persistent symptoms such as shortness of breath with exertion or ongoing chest pains after treatment for an acute pulmonary embolism. And so that concludes our slideshow for this evening. And we would love, and I hope that we have some questions to address from all of you. This is a time where, we're at our homes and we can sit back and answer your questions, whatever questions you might have about your acute pulmonary embolism, and try to answer your questions about CTEPH and what can be done about it.
So, Bill, here's a question. Can you have a PE without knowing it? It's a great question.
Then I think you should answer it.
Yes, you can.
Okay.
lots of times Bill and I have talked to patients whose symptoms really started and they were diagnosed with pneumonia or pleuritis. Sometimes it can be much more insidious onset of gradual shortness of breath, but acute pulmonary emboli can be misdiagnosed.
Yeah, absolutely. And it certainly is a challenge, for physicians. And because it can be quite sneaky, and pulmonary emboli can even be quite silent. And so the first presentation of somebody's pulmonary embolism may actually be CTEPH. And this is why we bring these seminars to you, so you understand that this is a tricky disease state, and also to really emphasize, that there's something that can be done once the diagnosis is made. And this brings us to a question that I found in the chat room. It says, what tests show whether your clots have resolved or whether you're forming scar tissue? Will a CT scan show this? How often and what timeline do you recommend following up tests to monitor? I assume what is asked is blood clots following an acute pulmonary embolism. That is an incredibly insightful question. And there are a number of studies that we do recommend to follow up whether or not the acute clots have gone away and whether or not scar tissue is formed, the chronic blood clots. And it's typically a CT scan, because that's the initial study that was performed when you went to the hospital. The suspicion of an acute pulmonary embolism was there, and typically that's the study that's obtained to make the initial diagnosis. So that's a very handy tool if read properly, that down the road after treatment, you could see where the fresh blood clots were initially and whether or not those fresh blood clots are gone or have changed so that there's that scar tissue within the pulmonary arteries. So a CAT scan is actually the test that's most often used in order to follow patients up after an acute pulmonary embolism. And there are no strict recommendations thus far, although there are some coming out, and that these kinds of evaluations should be done. Certainly, if symptoms persist after patients have been treated for 3 to 6 months after with blood clots. So if you've had your acute pulmonary embolism diagnosed, you're on anticoagulants for 3 to 6 months, depending on what's appropriate for you in your case, and symptoms persist, this is typically when we recommend follow-up studies be obtained, either echocardiography looking for strain on the right heart or pulmonary hypertension, and follow-up CAT scans. Often, for follow-up CAT scans or lung ventilation perfusion scans. So I know that was a very long answer, but those very insightful questions. And the key is, if you've had an acute PE, you're undergoing treatment, and you're still having symptoms after that period of time where you're being treated with an anticoagulant, that's the time to start looking for CTED and or CTEPH. And your doctor should know which studies to obtain.
Here's one for you, Bill. Where can patients find a good doctor for CTEPH?
That's a very good question. And there are a number of outstanding medical centers around the United States that have expertise in CTEPH. Now, Dr. Kerr and I have been doing this a long time, and it is our passion. It is something that we have been involved with. Kim makes it sound like I'm really the old man in the group, but I'm not. I mean, Kim and I have been partners now for 30 years. But UCSD has it probably has the world's largest CTEPH program. But that doesn't mean that there aren't other centers in the United States where physicians know a great deal about this disease and know what to do. There are centers throughout the Northeast, Mass General, Temple, Columbia Presbyterian, Duke, Florida centers. There are centers that specialize in the treatment of people with pulmonary hypertension, that specialize in the treatment of patients with acute pulmonary embolism, that know a lot about chronic thromboembolic disease. The key is to get to your doctor if you're having persistent symptoms after treatment and asking the critical question, listen, I'm just not where I should be, or I think where I should be. I'm really concerned that there's still something wrong. Are the clots still there? Do I need further evaluation? And that's the point. I want you to go back to your specialist or your internist and ask for an evaluation by specialists in cardiology, pulmonary, who know something about acute and chronic thromboembolic disease or pulmonary hypertension. So push the issue, guys. Okay, here's something, again, I'm in the chat room here. It says, shortness of breath for 4 years, had PE in hospital after mastectomy, but symptoms for years. And that's a lovely example. You had a pulmonary embolism, you were adequately treated, but yet your symptoms that are persistent symptoms. Now, I'm not saying that everybody who has that story is going to end up having CTEPH or CTED. There are other reasons why folks have, shortness of breath type symptoms, but it's important not to miss CTEPH or CTED, simply because there's so much to be done for that condition, and so it's very important to recognize it.
That's sort of a nice example that brings up the topic that you and I are very familiar with about the common delay in diagnosis.
Yeah.
And that's symptomatic. Patients are symptomatic a year, several years sometimes before someone even thinks about the diagnosis.
That's really, really a good point, Kim. And so, but that's the point of doing these webinars. That's, we, back in, 20, 25 years ago, not a lot of people knew about CTEPH or CTED. And so, but it's grown considerably over the years, and people do recognize that this can be a problem that can be solved after being treated for an acute pulmonary embolism. And 3 to 4% may not sound like a lot, but that's a big number considering that there are annually in the United States probably over 300,000 pulmonary embolism survivors long term. And so it may be more of a problem that is appreciated.
Here's a question. Is there anything you can do to lower your chances of these complications post-PE? Any protective factors? Another excellent question.
Go ahead, Kim. I'll let you take that one.
I am not aware of any. Are you?
No. Again, we're learning about the natural history of this disease. And even when people present with an acute PE, many of those individuals already have some chronic elements to their pulmonary embolism. Now, people say, well, what happens if you come into the hospital and we'll clot us? I'm doing okay. I'm on anticoagulants. Everything's going fine. what happens if I get some clot busters? Is that going to prevent me from developing CTEPH or CTEPH? And the answer is, we don't think so. And so just to get clot busters, just to prevent something from happening, we don't think that really prevents people from developing CTEPH down the road. So we don't know, is there a medicine you can take to prevent CTEPH from developing after a PE? And the answer is, we're not aware of any. And there's no research ongoing that's looking at that right now.
A comment here that this may not have much to do with the discussion, but I have continuous heart palpitations about 8 months after a large PE. I had a test some months ago that said the lungs were cleared, but now I can't sleep because of the palpitations. And I just learned I had sleep apnea. Again,
good. Well, first of all, I'm glad that people are paying attention to you and thinking about possibilities, because yes, palpitations, irregular heartbeats, atrial fibrillation, there are folks in which pulmonary embolism can provoke those and can make those kinds of symptoms occur. Your doctor looked at your lung and said they were clear, and now he's thinking of other things that can cause these kinds of palpitations at night. So again, that's a really nice example of, you're having a persistent problem, talk to your doctor and say, this is what's happening to me. And it sounds like your doctor's doing a darn good job trying to figure it out.
Any tips on where we can go to learn more, or how we can get more involved in supporting research? Oh, I'd love to hear that, short of having $1 million to donate.
Yeah, that would be kind of nice. Kim, I'm going to let you talk a little bit about this, because Dr. Kerr is also the director of a national CTEPH registry that is trying to answer some of these very important questions about who are at risk of developing CTEPH, what to do about it. So she's very active in the world of research. And we should all be very proud that she has done such a wonderful job with the registry in the United States.
Well, thank you. But Dr. Auger didn't mention that he's helped out a lot with that as well, too. Love to hear that patients are interested in research, because this is how we learn more, and this is how we improve care for patients. We do have a national registry. We're no longer enrolling patients right now, but I would encourage everyone who, if you're seen at a medical center that's doing clinical trials, to strongly consider participating, because we can't learn without your participation in our research. So please, if you're willing to do that, we are most grateful. And sometimes that research may not help you. Sometimes it might, if they're randomized trials that they invite you to participate in, but it may help patients in the future. So please do that.
And I always like to remind folks that, how we approach patients with acute pulmonary embolism and chronic pulmonary embolism is based a lot on the research that people like Kim and I have done, 10, 15 years ago. What we learned from that research, we now practice routinely in taking care of all of you today. And the same can be said for future research in the future, research that's currently being done. And so it's very, very important. In addition to, taking part in webinars like this, talking to your fellow PE survivors and, kind of passing the word on and being advocate for your own health. It's been a lifelong challenge for Dr. Kerr and I in getting the word out that this is a problem that has potential solutions, and it's very important. And we always hate to see the stories, or hate to hear the stories, I'm sorry, of folks that said, yeah, I had my pulmonary embolism 10 years ago, and I've been really, really short of breath and not feeling very well for the last 10 years. and they turn out to have something that we could have helped them with years previous, not waiting all these 10 years to be, short of breath with exertion, not being able to do the kinds of things that you can do because it just wasn't recognized. And so we're going to keep on doing these webinars. We're going to keep on trying to pass the message along. But the best thing you can do is be your own advocate and moving, hey, listen, doc, I'm just not feeling the way I thought I should be feeling after being treated for my PE.
Thank you both so much for a great webinar. And I really love that note that, we kind of ended on in terms of being an advocate for your own health as an organization that serves both healthcare providers and patients. That's why we do these things. So you can take this information and go back to your healthcare provider and ask better questions and really be involved in your own healthcare.